All right, good morning, everybody. As everybody's filtering in the back, we're going to go ahead and get started. So we have two PGY5 presentations today. Each will be 25 or 30 minutes. We'll hold questions till the end and try and stay on time. So first up, we have our own well-known Dylan O'Neill. He's no introduction, and he'll talk to us a little bit about the muscle-bone interaction and
Okay, so we're not going to use the mic because of that clicking issue we've been having. Can everybody hear me okay? Yeah, okay. So for the new fellows and folks I haven't met, I'm Dylan. I'm one of the PGY5s here. I'm going into trauma. And I'm going to talk today about the interaction between muscle and bone in the setting of fracture. And I apologize in advance. I think this may be a super clinically relevant topic one day. I don't really think it's at that stage yet, and I think it's more of an interest thing for me. But I hope we all treat fractures, and I hope that you guys will find this interesting too. It's a poorly understood area of basic science, and I'm hoping that this talk in the end will at least improve your understanding of the underlying biology in the area. So we have 25 minutes, and I hope to stay on track to talk to you about three things. First, we're going to review the overall process of fracture healing. I think that a global understanding of fracture healing is critical to understanding the role that muscle plays in the process. Second, we're going to talk about the prior limited research that led to my current interest in muscle-bone interaction and some of the dogma within orthopedic fracture care. And then finally, we're going to talk about some of the more current research that I believe is advancing our understanding of how muscles play a role in fracture healing. So honestly, I think this is where a lot of orthopedic surgeons get to in their career when it comes to the biology of fracture healing. Most of us can design an implant construct and at least have an idea of whether or not it's going to make callus or not. And we all know that there are medical and social risk factors for poor fracture healing. I think if you get to Dr. Rainey's idiot savant level due to your desire to dominate fellow residents on the OITE, you probably memorized some cytokines for each stage of fracture healing and leave it at that. But I think a limited understanding of fracture repair, while it may suffice for basic fracture treatment, if we don't understand the biology, we are oblivious to some of the problems that we face routinely in the operating room. So in order to make sure everyone's on the same page, we're going to briefly review the fracture healing process. And I'm going to use a review article from one of my mentors when I was a med student at Vanderbilt named John Schenecker. He's a pediatric orthopedic surgeon and a PhD in bone biology. And I think he's a really awesome teacher when it comes to what the process of fracture repair is actually designed to do. So I'm going to go through the highlights to this review paper, but for anybody that's interested, this citation is up there, and I think it's a pretty good read. So I think when you think about fracture healing, it's important to understand the biologic problems that the body needs to solve in order to heal a fracture. So acutely, there's bleeding and a huge increase in infection risk, and control of those things is paramount in the early phases of fracture healing. But once the body is not at risk of death, the fracture site must transition to a different phase where it restores stability and load-bearing potential in the dysvascular and hypoxic setting associated with a bony injury. So today I'm going to kind of talk through it with respect to endochondral ossification, but the process of intramembranous ossification or primary bone healing is very similar. It's just that certain steps can be omitted from this process because there's a low strain and high oxygen environment relatively early in the fracture healing process with intramembranous ossification. So the first phase of fracture healing is the survival phase. So it relies heavily on the coagulation cascade and pro-inflammatory cytokine signaling. Initial coagulation at the fracture site controls bleeding and forms a clot. And then as that clot matures into a fracture hematoma, the fibrin lattice work of the fracture hematoma serves as a natural infection barrier because the leukocytes can move along the fibrin lattice work and bacteria actually get trapped in it. Furthermore, within the fracture hematoma, there are platelets and dying tissue that provide important cytokine signals required to recruit white blood cells as well as mesenchymal stem cells to the fracture site. Once the initial insult is contained, however, the signaling environment in the fracture site must undergo a definitive transition. So we have to move away from an acute inflammatory phenotype to a reparative phenotype. And once the reparative phenotype is initiated, plasmid-mediated fibrinolysis and macrophage cleanup are hugely important to remodel the callus so that chondrocytes can proliferate. So chondroid matrix serves a hugely important purpose in fracture healing for two reasons. So the first thing it does is as chondrocytes proliferate, they resolve strain at the fracture site. This is hugely important because you can't have angiogenesis and subsequent bone formation without a stable site for the blood vessels and the bone to grow into. And then second, once the chondroid matrix has matured and strain is resolved, chondrocytes are key regulators of the vascular ingress and subsequent bone formation at the fracture site. And this is actually quite similar to how the physis works in normal bone development. Osteocytes require blood supply in order to exist. So there's old research suggesting that an osteocyte can't be in existence more than 200 micrometers from a capillary bed. And because of that, bone formation and angiogenesis across the chondroid matrix are closely tied processes that proceed in parallel until bony union is achieved. And then once bony union is achieved, the woven bone that makes up the initial bony union is remodeled for literally years after fracture initial union, as well as the vascular network. So there's a ton of remodeling that continues to occur even years out from the fracture. So to summarize, a more detailed understanding requires us to understand that fracture healing is a coordinated, time-dependent process that involves multiple seams of cells working together to heal the fracture in an orderly way. It requires a definitive transition from acute inflammation to a reparative state. Strain at the fracture site is reduced by a combination of our osteosynthesis interventions and/or the development of a cartilage matrix under hypoxic conditions. And the way that cartilage is transformed to bone is dependent on three things: a stable mechanical environment so that the vascular networks can persist, the presence of cartilaginous and osseous progenitor cells, and then coordinated vascular ingress across the cartilage matrix, similar to that occurs in the physis of a skeletally immature individual. So what's missing from the modern model of fracture healing? This is the most modern model I could find, but there's no meat involved. And I think that's interesting because from very early in residency, we learned that muscle is good for bone. This is to the point where we explain things to junior residents, like why you don't have to fix a scapular body fracture. It's, the bone's just covered in meat. It always heals. But we don't really have a good understanding in our field as to how muscle and bone interact at the basic science level, to the point where muscle isn't even mentioned in most models of fracture healing at all. So if this is the case, how well do we really understand the biology behind our operations? So everyone who's trained recently went to AO Basic, and we learned in the soft tissue management lecture that we're gardeners and not carpenters. But in my experience, the soft tissue management principles that are laid out in that lecture get translated into basically the same idea that every surgeon interprets a little bit differently. So Luke, are you with me? Say you're living out your dreams in a couple years and you're fixing this clavicle fracture on the right of the screen, but that pesky butterfly fragment, it's all tangled up in like platysma and deltoid and God knows what else. And you're really struggling to reduce it due to your obviously limited abilities. And then the devil appears on your shoulder and says, hey man, why don't you just cut all that muscle off? It'll make the fracture so much easier to reduce. But because you're a Utah resident, St. Higgins appears and tells you not to cut that muscle off. Why does he do that?
Yeah, he wants us to maintain the vascularity to all the
Yeah, and that's exactly right. I think that's how most of us think about it. Somehow the muscle being attached to the bone like magically gives that bone vascularity, even if the muscle is just barely attached by like 3 cell layers, right? And I think that the reason we think about it that way is because we all know the dogma of soft tissue friendly surgery, but we don't understand what else muscle could be doing to help the fracture heal. Like it must just be the blood supply, right? But despite the dogma and the importance of soft tissue friendly surgery, as I was preparing for this talk, I was interested to find out that there's really limited foundational research supporting those ideas that the muscle is somehow this magical blood supply conduit to the bone. And most of the current studies that we'll review later in this talk cite the same like 5 or 6 papers when they're justifying the relevance of their research. So we'll go through those really quick. The best early basic science on muscle-bone interaction basically all involves animal experiments where they look at different types of flap coverage and see how that affects an experimental fracture. So in 1989, Richards demonstrated that if he devascularized and took out a segment of dog tibia in the middle, it would revascularize at a much higher rate if covered with a muscle flap rather than skin alone. So in the middle section of this graph here, you see that the devascularized segment in the operated leg did much better with a muscle flap relative to skin coverage. And in their study, this corresponded to bony union in 6 of the 8 dogs in the muscle coverage group compared to just 2 of the 8 animals in the skin coverage group. More recently, there was a couple similar studies done by Harry et al. That compared bone healing at 28 days post-fracture in a mouse model of an open tibia fracture covered with either a fasciocutaneous or a muscle flap. And on the left side of the screen, the cortical mineral content of the fracture was the same between flap types. However, the load to failure was markedly reduced in the fasciocutaneous flap animals relative to the muscle flap animals. Again, supporting the idea that muscle is somehow supporting the creation of a stable bony union, right? Compared to even a fasciocutaneous flap. And kind of in contrast to what Luke and I were just talking about, the authors demonstrated in their set of studies that the healing benefits associated with muscle flap coverage were independent of vascularity. So the fasciocutaneous flap actually had more vessel surface area or vessel density at the fracture site than the muscular flap, suggesting that there's got to be some other means by which muscle is improving bone's ability to heal. And I thought that was interesting because I think it kind of flies in the face of how we think about fracture care on a day-to-day basis, right? In terms of clinical evidence in humans that there's a benefit of muscle coverage to fracture healing, there's very little directly relevant data. I think almost everybody who has treated fractures for a long time anecdotally knows that, you know, muscle coverage is good and high-grade open injuries are bad, but there's just not a lot of data to support that. And I think it's probably because the interaction between muscle and bone is a very difficult problem to isolate in a clinical setting. So there's so many factors that are relevant in these high energy injuries. I think it would be almost impossible to kind of study the way we study other things clinically in orthopedics. So this is a commonly cited study by Carladani et al. That investigated non-union risk in open and high energy tibia fractures. They studied 104 consecutive patients who were followed until fracture union or until a diagnosis of non-union was made. And in their cohort, open injuries had 8 times the risk of non-union, while high energy injuries had 2.9 times increased risk. I certainly think that those estimates are high, and I think that their study was pretty badly confounded because a lot of the high energy and open injuries were treated with external fixation, whereas a lot of the lower grade injuries were treated with internal fixation. More recently, there was a systematic review from Europe that looked at non-union rates as a secondary outcome for tibial shaft fractures in 3,060 open tibial shaft fractures. I think their analysis for non-union was limited by the number of publications that reported non-union rates. It was something like 4 publications of all their identified studies. And there were relatively low absolute numbers of non-union cases in the overall cohort. But they showed that the risk of non-union was higher in type 2 and 3 injuries, which we would kind of expect from our anecdotal knowledge when compared to type 1 injuries. And interestingly, their data suggested that type 3B injuries, which are the injuries that require flap coverage, actually had lower non-union rates, which would support some of the previous basic science we talked about that, you know, if those injuries are getting muscle flaps, maybe there's some benefit towards bony union that you could detect even in a large systematic review, which I thought was kind of interesting. The authors comment on it in their study, but they don't make that connection at all. They just said our stats must be wrong or our sample size must be low. In the last clinical study I'm going to show is Mehta et al. Attempted to evaluate radiographic healing of tibial fractures using a RUST score, which is a standardized score for grading tibial fracture union when comparing muscle coverage or fasciocutaneous flap coverage. And on the right here, you see they had a ton of different flap types, which to me suggests that this, patients in the study were treated very differently depending on exactly what injury they had. And I'm sure that limits the generalizability of their results, but they were able to show at 6 months that the RUST score was better in the muscle group than in the flap coverage group. So applying what we've talked about so far, we know that bone heals in a sequential orderly fashion that relies primarily on factors contained within the bone, particularly the periosteal and intraosseous blood supply and progenitor cells, at least if you believe the current modern models of bone healing. In addition, the AO and our mentors tell us that soft tissue friendly surgery and muscle are good for blood supply to the fracture. And there may be some limited prior evidence that supports that conclusion. So call me a skeptic, but none of what we talked about so far can explain how an injury like this could ever heal, because there's not like an ounce of periosteum left on that thing. Certainly the intraosseous blood supply is torched and the soft tissue friendly surgery idea has kind of flown out the window, right? I think injury, what's interesting though is that we can still get these injuries to heal with some frequency. Obviously this person is at higher risk of non-union, but it's not guaranteed, right? So I think that leads us to the Jurassic Park phenomenon, right? Like life finds a way. And I think we're learning with muscle bone interaction that muscle can kind of make up for some of the gaps that are created by a very high energy injury where the periosteum is disrupted and the blood supply, the intrinsic blood supply of the bone is essentially gone. So I want to finish the talk with some relatively new basic science focused on the direct cellular contributions of muscle in fracture healing, and then the paracrine signaling of muscle around the fracture callus that I think are really interesting and may change the way you think about what muscle is doing to help a fracture heal. So going back to our bone model of fracture healing, where do we think stem cells come from in terms of populating the callus with chondrogenic and osteogenic progenitor cells? Even as recently as 2018, this is a review article that's talks almost exclusively about the periosteal and endosteal stem cells as the cell source for a fracture callus. It also mentions bone marrow stem cells and pericytes, which are vascular stem cells, but there's no mention whatsoever of muscle-derived progenitor cells in this article. And overall, I would say the role of progenitor cells from the muscle is still not definitively clear in the literature. However, there's good evidence that muscle can contribute progenitor cells directly to the callus that play integral roles in callus formation. So Liu et al. Performed a lineage tracing study in fracture repair using a mouse model, and they used a mouse strain that had permanent MyoD labeling. So the benefit of that is if the cell's permanently labeled, even if it undergoes transition to a different cellular phenotype and loses all its external expression of muscle markers, you can still trace where it went. So they used a human alkaline phosphatase reporter to identify where the muscle-based stem cells ended up in a fracture callus. And that's indicated by this picture on the left. So the reporter is dark blue, and you can see that throughout the fracture callus in the open fracture group, there's a ton of HAP positive cells, suggesting that the stem cells that are creating that cartilage and even bony matrix are from the muscle and not from the periosteum. Interestingly, in a non-open fracture model where the periosteum wasn't stripped, there's almost no contribution of progenitor cells from the muscle, suggesting that maybe muscle acts as sort of a second periosteum in the instance of periosteal injury, which I thought was kind of interesting. In this study by Julian et al., they used grafts from EDL muscle and then from a periosteum into a mouse with an open model of a tibial fracture, but the grafts came from different strains of mice that had intrinsic immunofluorescent labels on them. So in the picture below, you can see that the Rosa donor, which is the red stain in the picture on the bottom, was the muscle graft, and then the GFP donor, which is the green stain on the bottom, was the periosteum graft. And it's you sort of have to take my word for it. They provide more evidence in the paper, but at the fracture site, at the cartilage bone interface, there's actually quite a bit of signaling from the muscle graft, suggesting that, again, those myogenic progenitor cells are heavily contributing to callus formation, particularly in the formation of chondrocytes, which would be, you know, kind of the first response in a secondary healing situation. The same author group did a similar study where they compared the contribution of bone marrow stem cells, periosteal stem cells, and muscle stem cells. So the bone marrow stem cells in this graph are blue, the periosteal stem cells are green, and the muscle stem cells are red. And they were able to demonstrate that while the periosteum in their model was the major source of stem cell for the fracture callus, there was a real and not insignificant contribution from muscle stem cells, where bone marrow stem cells, which we commonly understand to be a source of progenitor cells for the fracture callus, were not involved at all. In addition, they showed that, and I'm not sure I even really understand this, but at least they said they showed that once the muscle stem cells were exposed to a bone promoting cytokine milieu, the bone stem cells and the periosteal stem cells behaved almost exactly identically in terms of how they differentiated. So they went from a stem cell state to a fibrotic state to then a chondrogenic state, which would support that muscle stem cells can functionally do the things that are needed to provide support to a fracture callus and cause a fracture callus to heal, if that makes sense. The other thing I wanted to talk about was paracrine signaling. So there's a ton of articles on paracrine signaling in muscle, but I thought this was the best one that kind of highlighted the importance of paracrine interactions between muscle and bone. So the authors used multiple mouse models to kind of demonstrate this, but the first model was an open tibia fracture where they physically separated the bone from the muscle using a millipore filter. And then they analyzed the subsequent fracture callus using bone histomorphometry. And certain mice in this arm failed to heal their fracture at all. But in the left graph, you see that cartilage formation was delayed in mice with the filter implanted. And on the right graph, the filter implantation caused decreases in absolute bone volume at all time points in their study out to 28 days, suggesting that literally just physically separating the bone from the muscle can have, major effects on callus formation. And then in a separate experiment, they compared a PAX7 knockout mouse, which is devoid of muscle stem cell population called satellite cells, to a wild type control mouse in a closed tibial fracture model. And they showed that PAX7 knockout mice had significant deficiencies relative to the wild type mouse with respect to every aspect of callus formation. So decreased callus volume, cartilage volume, and bone volume at all time points. And this was independent of the vascularity at the fracture site, which was the same in both animals. So they also looked at the direct contribution of muscle stem cells to the fracture site. And in their research, they found, similar to the past study, that the muscle stem cells, at least in a closed fracture model, contribute very little to the actual progenitor cell mix. But because satellite cells were so important to callus formation in the PAX7 knockout mice, they wanted to see what else the satellite cells were doing. And they were able to show that at 3 days post-fracture, the satellite cells were heavily upregulated in all the BMP growth factor signaling pathways, as well as other important pro-bone cytokines like insulin like growth factor 1 and FGF2. So it may be that some of the stem cells in muscle actively participate in fracture repair more from a paracrine signaling perspective than from a direct cellular contribution perspective. So I hope that convinces you that, that study convinces you that there's good evidence that muscle acts on fracture in a paracrine manner. And I think it's likely driven, like I said, by some extent to the resident stem cell populations within the muscle. And researchers are already attempting to start harnessing these paracrine effects for therapeutic benefit. So this is a study from earlier this year where the authors studied the effects of irisin, which is a cytokine released from the muscle in response to exercise that has known osteogenic and angiogenic potential. So they did a mouse femur fracture model and they administered irisin systemically for 28 days following surgery. And they demonstrated that just one muscle cytokine could improve the fracture healing score at all time points and could improve the mechanical properties of bone, even with systemic administration. And in addition, they showed that at least some of this was driven by increasing vascularity at the fracture site, because the fractures in the irisin group vascularized so quickly that they ended up not even remodeling their vasculature at the end of the study, suggesting that they had already created like semi-mature bone at 4 weeks, which I thought was kind of cool. All right, we're running out of time here, but the last thing I want to talk about is that muscle injury can also have negative paracrine effects on fracture healing. So this is a study that used a rat model with volumetric muscle loss. And they found that just inducing volumetric muscle loss caused delayed fracture healing and decreased mechanical characteristics of the fracture site at 28 days without any other intervention. They also showed that the cause of this was likely upregulation of the inflammasome and the pro-inflammatory cytokine mix within the fracture site. And this is demonstrated by our PCR as well as this CD68 labeling study, which shows all these little red dots over here on the right side of the screen just demonstrate the increased leukocyte infiltration at the fracture site in the muscle loss group. And then that same group showed that they could rescue the muscle loss bone phenotype by administering tacrolimus, which targets pro-inflammatory cytokines as well as T cell activation. And so they basically did the exact same model that we talked about on the last slide, but they then administered tacrolimus and showed that by decreasing the inflammatory, insult associated with volumetric muscle loss, they could rescue the mechanical phenotype of bone, which I thought was pretty cool. So sorry, Jeff, I went a little over, but what I wanted you guys to take away from this is that muscle is more than just blood supply and fracture repair. So anytime you can get muscle over a fracture, it has multiple bone healing benefits that the body utilizes, especially in the instance of periosteal injury. And as we talked about, the way bone contributes to fracture healing is as a direct source of progenitor cells and through paracrine signaling pathways. The other thing about muscle injury is that the paracrine signaling can work against you if the muscle injury is severe enough in the area of the fracture. So it may be something to consider when you're treating high-grade injuries. And lastly, I hope some of those other studies at the end of the talk that show how we're kind of using new knowledge from the muscle secretome to maybe improve medical fracture treatment highlights opportunities that understanding muscle-bone interaction can have for improving clinical care. Thanks.
This is a great talk. You brought a topic. Think about it to us. That's the idea. That's the idea. For any talk in this group.
Well, we're getting set up. Maybe time for one question from the group. Dr. Jones?
So the functional definition of bone morphogenetic proteins, this is probably, I don't know, almost 40 years ago now, was that they could inject these proteins into a muscle and it would form an ossicle of bone. And it would even form a marrow space. I mean, like the whole bone intramembranous, ossification program sort of happened. Has anybody gone back, now that they're using these kinds of tracing techniques, to see where those bone stem cells come from? And are they coming from muscle satellite cells? Are they coming from?
Yeah, I didn't understand the literature that I found on that well enough to feel like I could present it, but there are multiple studies that have tried to suss out exactly what the stem cell progenitors in muscle are. And there's multiple different populations. So there's like tenocyte-like muscle stem cells, there's satellite cells, there are these fibrogenic progenitor cells that one of the studies I read hadn't even had classified a name for, basically. So I think most of the studies I read on that subject would suggest that there are a bunch of different progenitor cell types within muscle, and those are the cells that are dysregulated in things like heterotopic ossification or in the BMP signaling you're talking about. And they are all, regardless of whether they're from the periosteum or from the muscle, almost every muscle progenitor cell is activated to some extent by the BMP pathway. So it's like the common pathway for activation. I don't know if that answers your question, but
That's great. We can talk more about it.
Nice job. Thanks, Tom.